Hello, everyone who's joining on. My name is Dr. John Marshall. We're going to get started in about 1 minute to let people have some time to sign on. We will have 30 minutes together, so hopefully that will be enough to get your questions answered. So let's just give everybody about another minute to log on before we get started officially. You are coming live from my basement in Arlington, Virginia. And we think we'll have a pretty good size audience for this. So give it just a few more minutes and then we will jump right in to our discussion. I hope everyone out there is staying safe and not going too stir crazy. I know there's a lot to be anxious about and a lot to worry about, and hopefully we'll answer your questions and address some of your concerns during our discussion today. So give it about another 30 seconds and we will jump in on our review. I am being communicated with via a text here and there. So let me just make sure my team on the backside is doing okay. And with that, we will get started. And make sure that we've got everything working. All right, it is 11:02 by my phone. Let's go ahead and jump in and formally get started. So I'm not sure welcome is the right term, but I do want to welcome you to our Facebook chat. Our topic is COVID-19, as with everything else, but in respect to cancer and its impact on cancer. Let me just check one more time. Good. My name is Dr. John Marshall. I'm a medical oncologist at Georgetown University's Lombardi Comprehensive Cancer Center. I'm the clinical director there, overseeing all the operations for the cancer center. And I'm also a GI oncologist. But apart from our world at Georgetown, we really want to welcome all patients with cancer and their families and caregivers and those of concern, and maybe some staff members who are also logging on to this as well to kind of discuss the issues as we move forward over the next few weeks. So just a bit of housekeeping. We do invite questions. I think all of you have a chat function on the Facebook page, so you can ask questions. I've got folks who are busily sort of compiling those and then feeding them to me so I can answer those. So we welcome that as we go along. I do want to put a major disclaimer. I'm not in a position right now to offer people specific medical advice. The punchline to all of that's going to be you need to check with your healthcare provider as to what their advice is for you. We'll be talking in general terms, and the hope is that this will give you some insight about what's going on in our shop, what we're trying to do, and also some advice back to you. Are you different as a cancer patient or a caregiver of a cancer patient that we need to be aware of? So with that disclaimer, we're happy to jump in. Now, I want to start with the big picture concept that cancer is not elective, right? So a lot of elective hospital things, having your hip replaced or some sort of dermatologic thing, whatever. There are things that are sort of not urgent, and therefore elective and can be postponed. And we've done a lot of that, but you can't really elect out of cancer and cancer care. So whether it's somebody who's getting a brand new diagnosis, because we know that's happening daily to lots and lots of people, or it's people who are just beginning their journey to battle their cancer or to treat their cancer, or it's patients who had cancer in the past. They are all these concerns and issues that we can't really stop those things, at least cold. We can change them, we can modify them, but we can't stop them cold. So on our front, just to re-stress this, is that we can't turn off the cancer center. We have to maintain cancer care for you as our patients, and this is all cancer centers, because we know that need needs to continue. And so we are making decisions day by day on individual patients and as a group on how best to continue to deliver optimum cancer care, balancing against the sort of risk of infection and concerns about our own our staffs and your public safety and our safety. So we just have to start with that concept that most cancer care is not really elective. I want to touch base on just a few topics which might take 10 minutes or so, and then open the field for questions. So feel free to ping questions in as we go. One of the things that we are trying to figure out as quickly as we can is, are cancer patients at any stage in their journey at increased risk of getting the infection? That's first. And then if you get the infection, are you at increased risk of getting one of the severe consequences of the infection? And just to remember everybody, most people who get the infection either have no symptoms or a cold-like syndrome. I mean, sometimes you feel pretty crummy, a flu-like syndrome, but don't need a hospital. What's different about this virus is that there's a group of patients, people who get infections, who get very sick and need to come in the hospital. And then the ones we worry about the most are the group of them who get so sick that they need intensive care unit support. And of course, we're all recognizing, because we're all watching the same news feeds, that some of those people, in fact, die of that. Despite all of our modern technology and care, there is a smaller but significant subgroup of people who are dying of this despite all of our ICU care. So are cancer patients at an increased risk through that process? Now, we're learning as fast as we can learn, okay? So we are in constant communication with our colleagues in China, our colleagues in Italy and other parts of Europe, and New York and the West Coast here in the States, to share as much as we can know about the patients that are getting sick and coming into the hospital. And there were some early reports out of China of a small group of patients who seemed to have a higher risk, and these were cancer patients, higher risk. A lot of those cancer patients were lung cancer patients. It's been yet to really replicate in other centers. So we're going on thin data, thin amounts of data. But what we are basically assuming is that, yeah, maybe you're at increased risk. A cancer patient is at increased risk of catching it, but also what we're more worried about, increased risk of suffering consequences. Now, that might be because of some alteration in the immune system, maybe either acutely getting treatment, but there's also some suggestion that patients who had past histories of cancer might be at increased risk too. So we're just treating everybody as if you're at some increased risk for having a serious complication of the virus. And so we're doing everything we can to balance the risk of you getting an infection by, say, coming to the hospital versus the need to continue your treatments. So that's why each one of these things is a very individual scenario. On the flip side, we also are pretty worried as healthcare providers, to be blunt, is that, yes, we're on the front lines, and yes, we are preparing here in Washington, because we're a little pre-surge here, but just like our colleagues in New York and other places have done, we are preparing to be deployed or exposed more, if you will, the front lines where people are getting infected, or the infected people are in our system. And we know that a certain subgroup of our staff will likely get infected. And then if the math holds up, then a subset of our staff will suffer severe consequences and maybe, yes, die. So it is possible that over the next month that hospital providers, doctors, nurses, everybody, technicians, everybody who's working in the front lines will risk the infection. And as the percentages go, whether you're at risk or not, there are people who are dying as a result of this exposure. So on our side, too, we're trying to do everything we can do to protect ourselves, because we are no good to anybody. If we get infected, then we get quarantined. So that reduces our staffing. Or even more seriously, if somebody gets infected and requires hospitalization or risks dying, we certainly want to avoid that as possible. So all of us are in the same boat of trying to protect ourselves individually at the same time of optimizing the ongoing care we need to do. So we're spending a lot of time and energy trying to figure that out. Now, one thing that I want if there are cancer patients listening in right now, is active treatment patients. We are already modifying our practice to minimize your risk. So you may have heard about telehealth. We're doing a lot of this, where we now have clearance from the officials that oversee our practice that we can actually provide healthcare by this sort of vehicle, by a video conference. And we can see you. Obviously, we can't examine you, but we can get pretty good along the way. And so that prevents you from having to come to the hospital to interface with us and risk that exposure at a hospital. We have not figured out yet how to give you intravenous treatments, for example, without your coming to an infusion unit. So that still means you need to come in. Laboratory testing that so many cancer patients do, they need to go someplace. There are some centers that are having, roving phlebotomists, if you will, come to your house and draw that. And so we're thinking about those kinds of ways to minimize your risk as well. One of the strategies that many of us are using for particularly patients who are on their treatment and the treatment's been going pretty well, is to either skip a cycle, to just completely skip it, delay it in some way, modify it from an IV to an oral regimen. Again, all of these things are being considered and done solely in the name of preventing exposure to each other, to minimize the risk for you, to minimize the risk for us. So we're in case-by-case basis, we're trying to balance those things. The other thing that has come up, at least in our center, and may be affecting some of you, is that what is really elective? Patients who are undergoing cancer treatment need lots of procedures. They need, whether it's a palliative procedure like radiation or the chemotherapy, or they might need some stent put in or an endoscopy that needs to be done. And as you know, we're trying to minimize elective procedures. So, we are trying to navigate what really needs to happen now, whether that's to relieve symptoms or to improve outcome for patients that might be considered elective, where we say, no, we think you should go ahead and do that, versus say, no, let's delay it until we know more and figure those things out. In terms of the most basic visits, so these are like long-term follow-ups or routine cancer screening, these kinds of things. We are pushing those off. Unless there's something highly suspicious that we're chasing, somebody's found a lump or a bump that we really need to figure out today, we're pushing off, whether it's your routine blood work or CAT scans or doctor visits. Many of our visits are being done by telehealth, just to make sure you know that we're all okay and you seem to be okay, and let's see you back in 3 months or so. Kind of strategy. So, routine screening for cancer is on hold for many of us, unless, of course, there is a fairly high risk of something going on. And then the last thing that I wanted to emphasize is clinical research. We and other cancer centers all across the country are actively engaged in clinical research. And those patients who are on clinical trials already or are just about to start, we've at Georgetown, very similar to many other cancer centers, have basically said, we're going to keep you people on your trial. But for the most part, we are slowing down access to clinical trials, again, because this requires additional staff and additional exposures, unless, and our policy, for example, is unless the trial offers access to a medicine that you couldn't get any other way, that is truly, a big big deal medicine. So we're trying to make those value judgments as well on individual patients and individual clinical trials so that you still have access to those things for those patients in most need, but at the same time trying to minimize risk to both you and to us as providers. So far, there have been no shortages of cancer medicines. I have heard of no staffing issues yet for our nurses in infusion, our nurses in clinic. And this is nationwide because we're all watching each other as we go along. And physicians are available. Now, what we're anticipating over the next week or two is that because we are also cross-trained, right? We're internal medicine doctors and we can do other stuff, that it's possible that many of us will be called to help probably backfill other primary care docs. So the primary care docs probably will help be on really more frontline of COVID patients. Those who are more recently taking care of patients in ICUs, they kind of move forward. And then we specialists will probably move in to backfill them. But in our world for oncology, and part of our job is to keep our attention in both directions so that we are helping our colleagues and backfill what they have left behind to care for those folks with COVID, and also maintaining our cancer care for all of you all who want that and need it and continue to need it. So we're anticipating over the month of April here in Washington, D.C., at least that's when our surge is expected, for us to have to shift in that. And so that's just in pure transparency what we're talking about and how things are going on our end. So I've gone on a little longer than I should have, but let me see if we've got some questions out there. And so if anybody's got questions, please feel free to enter them. And I will try to address them in specific. While I'm waiting for that, there have been at our hospital, we have masks at the moment, but we are doing things like strategizing how to reuse them, how long to use them. We want everybody wearing masks, caregivers, patients, physicians, nurses, everybody's to be wearing masks at the moment. It'll help a little, won't solve it, but it'll help a little. We're spending a lot of time using our research and smart people that I work with as well to figure out other treatments for COVID, right? That a lot of the cancer treatments, turns out, some of the medicines we use there might actually apply in the management of COVID infections when they get more severe. So we're helping out our infectious disease colleagues and our ICU colleagues to try and not just endure what's coming, but to try and fix what's coming. So we're hopeful that the more time we have and the more lessons we learn from other centers, other regions of the world, that we can apply those to our patients and ourselves, quite honestly, here. So let me pause. Let me ask if there's any questions. So we do have one. So risk benefit of modifying or stopping treatment. That's a great question. And that's one of those things that we're judging daily. Let me use an example of somebody who's on, chemotherapy for, that comes in every 2 to 3 weeks for their treatment. And let's say they've been on it for 6 months and things are going pretty well. I would argue that skipping a cycle or delaying a cycle would have almost no impact on that patient. And so those are fairly easy ones for us to say, you know what, take a break from that. Whereas somebody whose cancer is much more aggressive and the treatment has been needed to, keep it even where it is, those are patients that we would prioritize maybe delaying a week to minimize exposure or doing a telehealth visit to minimize exposure, but still maintaining treatment. And then also, of course, if we really think you can't afford a break, then switching to orals, this sort of thing is a strategy as well. So those are individual risk benefit decisions that we're making. Some of our treatments, by the way, they cause drops in blood counts. And so in some cases, we have kept you going, but modified the doses in such a way to minimize the chances that your blood counts would get too low, sort of splitting the difference, if you will. Another question was, can I access other services like genetic counseling and dietitians at the cancer center? Currently, yes. I mean, for our center, we can, although I will tell you that those are the sorts of services of a comprehensive cancer center that might get thinner as other people get pulled in other directions. Cancer genetics sometimes is acute and sudden, and so we want to have that for people who need it right now for decision making. But also it's one of those things that could be delayed for discussions later. Some of that can be done remotely, some cannot. So our intention is to try and provide that as best we can, but my guess is that we won't be able to maintain it to the same level as we do all the time. But that's our center, and so we'll keep doing everything. Different centers may be making different decisions about that. One of the viewers has asked what I think about the drug hydroxychloroquine. There's obviously a lot of discussion about this malaria drug. It's being given in combination with a Z-Pak. There is some early evidence, small studies that have reported, even now, that suggests you can decrease how much virus is involved. What our team is focused on, some smart people have looked at this, is that the dose needs to maybe be higher. Doesn't mean go out there and do this yourself. We know some person died of an overdose trying to do it that way. And probably needs to be started earlier if it's going to be a benefit. So I think the jury is still out. Now, that doesn't mean we're not trying it, and our teams are, for those patients who are infected, there's a lot of discussion and use of those kinds of approaches, and it may be helping. And so we are trying to access that and provide when appropriate. But that's not really my area. We're going to leave that to the infectious disease and the ICU teams for that answer. All right, another question. How are we on time? We're doing fine. So benefits you've seen for patients who've shifted to telehealth. Well, so far, there's only been positives. I mean, let's face it, parking lots, and nobody really wants to go out, but you want to know that you're doing okay. And so more than a phone call, this be able to see each other, I think, matters. It matters to patients and to physicians to make the best judgment of how you're doing and to transmit the information that you're trying to get in both directions. So far the feedback, and we're only a couple of weeks into this at Georgetown, has been very positive on both sides, physicians and patients. Of course, we're rolling out an SOP very quickly. And so there have been some bumps about, people not getting the link and things like that we're trying our best to close down. It won't ultimately replace the need to come and see physicians every now and then. But for right now, I think everyone's pleased with this kind of access in connecting, prioritizing, and decision-making going forward. So far, so good with that kind of approach. Any other questions from the folks out there? Any other issues that are worrying you? I'll give it a few minutes. Here's something else. Yeah, oh yeah, so this is a great question somebody asked about privacy.